So we talked about the importance of being able to identify how the patient is able to see when we add head movement. And that's a function of the vestibuloocular reflex, especially as the speeds get faster and faster and faster. We had a comment that it's easier to start the testing with the dynamic visual acuity first because it's an easier test for the patient and for the operator. The reason gaze stability was originally first in the protocol is because they wanted to give the patient an opportunity and the operator an opportunity to see if the patient could even reach speeds of 85 to 120 degrees per second. Because if the patient was scoring in very low speeds, 50, 60 degrees per second, then you wouldn't move on to dynamic visual acuity because you would assume that the patient couldn't do it anyway. But what I've found is if I get the patient started on DVA, it doesn't take me very long to realize if they can't see, and it's an easier place for me to start. But the benefits of the computerized testing, like we talked about earlier, is that the patient isn't able to cheat. You can differentiate the right from the left side, and you can get very good accuracy on speed of retinal slip. So let's start by talking about the VOR in general. The vestibuloocular reflex is one of the fastest reflexes that we have in the body, and it needs to be very, very accurate. What happens to patients if their VOR is not working? What do they complain about? Blurred vision during head movement. Blurry vision or that their visual field doesn't seem stable to them as they're turning their head. And what types of patients do we have that have these types of complaints? Where do you see this? Yeah, somebody with a vestibular asymmetry, so a unilateral vestibular loss. Patients also with bilateral vestibular loss can have significant trouble maintaining gaze stability. Who else has trouble? What about your older adults that tend to slow down their head movement in general? Okay, if you try to challenge them by speeding up their head movement, they might complain of dizziness or blurred vision. So this is a really nice test for sort of your typical patient, your balance impaired patient, your fall risk patient. It's also becoming very important for concussion rehab and concussion management. What we're seeing from the field is that when we treat a patient with concussion, there are things that improve quite quickly. The SOT improves usually within about 10 days or 2 weeks. But the dynamic visual acuity can take much longer to improve, and especially the gaze stability at fast speeds. If we're talking about athletes, they need to be able to see with their head moving at very fast speeds, and we're finding that the patients that have a concussion, it's taking them longer to return to their baseline after that concussion. The protocol for this is that we start always with static acuity and perception time to get a baseline so that the computer has something to compare against. And we recommend that we start with dynamic visual acuity and then move on to gaze stability. When the protocols were first developed, the protocols were that the optotypes would be presented sequentially, line by line by line. So the optotype would be big. If you got it right, it got one line smaller, it got one line smaller, it got one line smaller. And it took a really long time to complete the test protocol. So what we've changed to is a convergence algorithm, which means that the optotype is going to be presented. And then if the patient gets it right, the next optotype is going to jump a few lines. Patient gets it right, it's going to jump a few lines more. And then if the patient gets it wrong, it's going to jump up just a little bit, and it's going to slowly narrow in on the exact level where the patient is having the most difficulty. As I said earlier, you will be able to see that the computer will give the optotype repeatedly at a certain level because the computer's going to look for consistency. It's not just one right answer or one wrong answer at a level. It's multiple right answers or multiple wrong answers that will allow the computer to know if that's the true level that we're looking for. The perception time test allows us to see how quickly the patient perceives a visual optotype. If the patient is normal, those scores are going to be between 20 and 50 milliseconds. If the patient scores 60 milliseconds or higher, what do? We don't go on to dynamic visual acuity testing. We repeat perception time. If we do not see that the patient can score within the normal range on perception time, it's not recommended that we go on and do the dynamic visual acuity. And you will get an error report on your analysis. If you do go on and test, it will say that your results are not valid because of prolonged perception time. There is a learning effect to all these tests. So if your patient scores abnormally the first time you do perception time, give them another chance at it. See if they can do it the second time through. We report the results in both Snellen and Logmar. There was a question on what's the largest optotype that the computer will show, and it's 1.0 Logmar adjusted for the patient distance. So how many lines above 20/20 is 1.0 Logmar? 10. 10 lines bigger than 20/20. So it's a pretty big E will show up there. Yeah, and that would be equivalent to 2200. So if your patient can see at 2200, they'd at least be able to start the test. They might not be able to get too far into it, though. Okay, dynamic visual acuity. What are we asking? We want to know how well can the patient see with their head moving compared to their head still. So it's going to allow us a way to see how the patient is functionally using their vestibuloocular reflex. Remember, this is not a diagnostic tool. We're looking at how the patient is using the VOR. Similar to the SOT, we're looking at how the patient is using vestibular cues for balance. Same thing here. We are looking to see how well the patient is using the vestibuloocular reflex. The DVA tends to be an easier test to perform because the head velocity stays constant throughout the test. It's very similar to the clinical DVA. The head velocity stays between 85 and 120 degrees per second. And as the test advances, the optotype gets smaller and smaller and smaller and smaller. Then the results that you get, the computer will indicate the comparison of head still to head moving. And that's that DVA loss report. And you'll be able to tell how many lines the patient lost when we went from head still to head moving. The gaze stabilization test is a little different. What the gaze stabilization test is asking is how quickly, what's the maximum velocity that this patient can move their head and still maintain stable visual clarity. This, for the rehab therapist, the vestibular therapist, this is a really nice tool because it actually gives us the precise speed at which retinal slip occurs, and it'll help us develop our home exercise programs to be very specific to the patient. We can also compare left side to right side. Just like the DVA, we can compare left side to right side. And this is going to give us more of an idea of how the patient has compensated for their vestibular loss or their injury. The test is a little trickier because as we move through the test, if the patient gets the answer correct, the computer will ask for faster head velocity because the goal is to see how quickly the patient can actually move their head and still see. So the instructions to the patient are going to be a little different. They are gradually start increasing your head speed, and as soon as the patient hits that threshold velocity, the optotype will appear. If the patient gets the answer wrong, then the computer will ask for a slower head velocity on the next trial. Both the DVA and the GST require practice. I highly recommend that both you as the operator and your patients have practice trials because it will really smooth out the consistency of your data. Most of my patients are traumatic brain injury or concussion patients, and so the neck is always a consideration whenever you're asking the patient to do any testing with head movement. So it's really important that you're looking at the cervical spine in your exam before you do any of these tests. The gaze stability test allows us to see how the patient might do during functional activities. We know from the literature that high demand sports require faster VOR speeds. We also know that the VOR is highly adaptable, trainable. So this is an interesting thought for patients that are doing high performance sports, sports injury management, and also sports performance enhancement. Our normal ADLs usually happen between 75 and 120 degrees per second of head movement. So that's kind of the normal place where we live. We're doing normal activities. We're doing walking, moving around, getting dressed, going to the grocery store, those types of things. If your patient is unable to function, to see at that 75 to 120 degrees per second level, which is where the DVA is, you can still test them on the gaze stability test, which will offer you slower head speeds so you can capture truly where they are and get an idea of what they should be able to do from the ADL perspective. This is what our data looks like on the GST. What you can see is that the trials are listed in order. So this was a patient who had 27 trials presented with sweeps to the left and 15 trials presented with sweeps to the right. The first one, you can see that the first one, the patient's moving at 181 degrees per second. What mode were we testing this patient in? High performance, okay? So the patient, this first one is red, 181 degrees per second, and it's red, and there's a red minus here. What does that mean? What happened during that trial, and how did the patient perform? The patient moved too quickly, so that's why this one is red. 181 was too fast. And did the patient get the answer right or wrong? The patient got it wrong. So you're concerned, what could this potentially be? A false positive result because the patient was moving too quickly. So as the operator, what's your cue to the patient for the next one? Slow down, okay? So that happened a couple of times. And then we see some greens here. So the patient was able to reach the threshold velocity, and a lot of pluses. The patient was getting the answers correctly. And then over here, when the patient was tested on the right, what does this F mean? Failed to reach the threshold velocity. So you'll see that there's no plus or minus there because the optotype wasn't even presented. So this data allows you to compare left side to right side, and it also allows you to see how the patient performed. If this data is collected throughout the test. What if your patient halfway through the test says, I need to stop. I'm not feeling well, I have to stop, and you haven't gotten a score yet? Let them rest. If you have to stop the test, the good news is you still have this. So you will be able to go in and get a good sense of their speed and their accuracy. So if the patient can't complete the test, you'll still have raw data. Okay, you'll just stop the test, you'll save the test, and when you go in and pull up the raw data, you'll be able to get an idea of how that patient performed. Question? The computer decides that based on consistency. Also, the more Fs that you get, if you are not able to move your head at the threshold velocity, the computer is not going to keep pushing that. So the computer's going to actually truncate the test a little bit. You can actually, if your patient isn't reaching the threshold velocity, the test may actually end a little bit prematurely because you're not at that point testing the VOR because you're not able to push them to their maximum speed. So it could be a cervical limitation that you're looking at instead. So you have to look at your results through the lens of the raw data. Could be. If you've got a lot of red, well, if you've got a lot of red negatives could be false positive results. If you've got red and they got it wrong, red wrong, I have a concern. But what you see here is some of these are red, but they actually got them right. So you're not concerned about those. You're only really concerned if they went too fast and they got it wrong, because it could be a false positive. So it's always a good idea if you're questioning your data to go back and retest. You'll get some red flags on your reports if the patient got those Fs. Did not perform higher head velocity will appear on your report, and at that point you don't know if you don't know the patient's true VOR limitation. All you know is their cervical limitation. For those of you that tested in the normal performance and you maxed it out, we may not know your true maximum head speed because we didn't test you in high performance. And the same goes true with your patients. And then again, a reminder about perception time. If your perception time is prolonged, your data may not be accurate. This was some of the validation study that was done looking at practice and the importance of practice. One of the most common calls I get from people in the field is, I feel like my data is inconsistent. And my first question is, did you practice and did the patient practice? Because you can see these tests are not easy to administer. These are our most complex tests, and it takes a lot of practice, especially on the part of the operator. We do have some nice specificity data and reliability data on this test. Okay? This was a study that was done looking at patients with unilateral vestibular loss. So for the therapists that don't have access to vestibular function testing, if you are finding that your patient is scoring with a big asymmetry on the gaze stabilization test, that might help you be able to advocate for that patient to get vestibular function testing. The perception time, if your patient is scoring abnormally long in perception time, remember these are patients often that have central nervous system dysfunction, brain injuries, or they're on some central nervous system depressive medication. They're using this as an indicator for readiness for rehab. Once they hit that normal range on perception time, you're going to do much better with rehabilitation because then you are really able to test and train the VOR and you're not going to have these long delays in perception. Like we talked about earlier with the ability to use a metronome for training, after you test your patient and you want to set them up on a VOR ×1 training protocol, how are you going to do that? What are you going to use to help you set that up? What mode? Practice in which test? Practice in gaze stability. And I just learned at the break that there are metronomes that actually have a tap feature so that you can set the metronome based on your patient's head speed. And then the patient goes home with that speed set in the metronome to practice their VOR. Any questions on dynamic visual acuity or gaze stability? Practice is critical. All right, thanks.